Hi, welcome to CARE Samvaad with me, Murchi Hemant, and Nato Paatu unnaru Dr. KC Misra Saab. Doctor, firstly, welcome to CARE Samvaad.
Thank you very much, Samanji. I think maybe I know less. Now I am coming to know more about you. That is a great part. No, yes, thank you very much to be having me here.
Yes. Sir, when you say there are so many kinds of, say, segments or sectors with regards to medicine in today's terms, right? However, across all this, what drew you to be part of critical care as a specialty?
See, I will add some prefix,
Yeah.
then the reason, and maybe afterwards what is happening. See, critical care per se in medicine, no, it is one of the newest branch. It is there in existence since last 75 years only. If you see medicine per se, which is there for maybe 500,000 years, we don't know like how many years also. If you see, the first person is not a doctor who thought of critical care, that was Florence Nightingale. That was a chimera war. When she has seen that a lot of people who are like war victims, they are dying because of not getting the attention what they are supposed to. She has only one smallest change. Those sick patients she kept in front of the where the sisters are staying. That is the first thing, very, very simple trick what she have used. By that the monitoring improved and lot of people they saved because only observing them more frequently the sicker group of patients. That was the first thing what you would see in critical care, observation and monitoring. And for me, my observation was always good. I always can pick up things much faster than others. That, and second thing is critical care is a thing where we can life and death matters. So your minutes, your hours, your decision can make a patient survive or die.
Correct.
That is what I have seen, and that fascinated me to a level that no, I should do in critical care only. During my post-graduation time, I was more inclined towards critical care because of the same reason. And once a sicker group of patients where, let's say, the patient would have died, the whole family is tensed. And that point of time, you are doing your best to make sure that patient survives and go home, working out of the ICU. That kind of satisfaction no other facility can give you.
Wow.
So I have few instances during my post-graduation where I have seen like critical care is one of the branch where you can really save lives if you do it properly and correctly. That drove me towards critical care. Now I am here in critical care since last 18 years, never thought of going back. Yes, the tension, the demand in critical care, the amount of pressure, what you take day in and out is maybe much more than any other branch, but still the satisfaction what you get when a patient get out of the hospital with such a sickness where you would have died otherwise, that is different kind of pleasure what you can get out of life.
Sir, how did your training in global institutions shape your thought process, at least with handling complex situations in the ICUs?
See, per se, if you see the whole critical care, as I've told, which is shaping out throughout the world in the last 40-50 years, in India things are evolving day by day. If you will ask me, is there any gross difference between the Western countries' critical care in India, what we are doing right now? Not much. And more so in the tertiary centers or maybe the big cities, what we have right now, let it be your Delhi, Mumbai, Hyderabad. Hyderabad is a hub right now when it comes to hospital care, health care and ICUs. We do anything and everything what a Western country person out there they can do. I have seen the few things what we should learn from there is a part of, let's see in India or what we should implement here is their punctuality. One of the biggest thing what we always lack in India, not like I am telling it is like 100%, but still. And second thing is the protocols and the way they stick to the protocols. It is not like a senior most person or a junior most person. They stick to the protocol from the first point to the last point without any diversion. Third thing is the way the system works. Yes, we are evolving. Now things are much better in India. If you come to any of the tertiary hospital like our CARE, the system and process run so smoothly that you cannot differentiate it than any other bigger hospital in any Western country hospital. So yes, one more thing I believe where we should excel that is the more of studies or maybe the research part in India which is lacking compared to Western countries. That is one thing we should improve, and we are doing it. Hopefully in the next 5-10 years things are going to change drastically in India also. But when it comes to patient care per se, the technology what they have, and maybe the circumstances, the things are evolving, and we are almost equal to any of the Western countries. What they do right now, we do almost everything.
Yeah. And also, sir, the next word that we keep hearing, but we don't understand anything about that, is ECMO, ECMO. What is ECMO and when is this used?
See, ECMO is a newer thing, no doubt about it. I am maybe fortunate enough to have very good exposure when it comes to extra ECMOs. ECMO, the full form is extracorporeal membrane oxygenation. So this is kind of a machine which is situated outside of the body, where one's patient's blood has to go through that machine. So there the blood will get oxygenated and carbon dioxide will be removed, and that oxygenated blood, the way the lung work in a normal person, will be pushed back to the patient body again. So ECMO basically helps when somebody's lungs or heart, or both the lungs and heart, is not at all functioning, or if at all functioning, it is not able to support or cope up with whatever different form of support you are trying. So ECMO sometimes is the last resort when your ventilator, your cardiac support medicines, nothing works. And we believe the patient is not going to survive with best of your efforts and supports whatever available at that point of time. We think of ECMO.
Are there any extra benefits the patient gets with ECMO?
See, there are, if we are thinking of ECMO, there are different scenarios. I'll just give an overview of the scenarios. We can't go and deep into the each and everything because it is impossible to discuss within this 20-30 minutes. ECMO basically, let's see if somebody's lung is failing, with ventilator, with all your supports, things are not improving. You know that oxygen is really, really required. If oxygen you are not able to maintain, the patient's each and every organ will slowly go into dysfunction and patient will ultimately die. That is the situation when you are thinking of ECMO. We give rest to the organ which you are supporting, let's say the lungs or heart. We give the best possible chance for that dying organ to heal by itself. Okay, that is called ECMO till recovery. But most of the time recovery doesn't happen. In that case, sometimes we go with transplant. Let's say lungs are so bad and the patient is dying by best of your effort, then you put them on ECMO till we get a lung for transplant. So lung transplant, same thing with the heart transplant also. Sometimes we do it as a bridge to transplant, bridge to therapy also. Let's say we had a case where the heart already which was very weak, he has underwent surgery for the heart, multiple stents, he had multiple cardiac dysarrhythmias where your heart is beating irregularly, he had multiple cardiac arrest. We felt we are losing him, we started on ECMO because we didn't have time. We felt like there is no way he is going to give us more time. Then after a period of let's say 15-20 days of ECMO, we place that patient on a LVAD. LVAD is a thing which can support the heart. And afterwards, he has underwent heart transplant. He himself was a cardiologist from Chennai.
Oh.
And it is a story like a legacy what we have done long back in CARE.
Oh.
And that person till now is working fine and living happily. So these are the few things like bridge to recovery, bridge to transplant, or bridge to decision like this, where we didn't have a decision to make. Otherwise, the patient would have died.
Yeah. And also, sir, when you say ECMO, it's very complex. It is very resource intensive, right? So at what stage do you suggest the patient that they should go for ECMO?
See, now, no doubt, as you told, it is a resource intensive. And second thing, in India, when the patients, most of the patients are paying from their pocket, it is no doubt is costly also, or expensive therapy, what we can offer to a patient. So because it's a labor intensive and difficult to initiate, maintain and all, it requires a dedicated team to maintain an ECMO patient, a patient who is on ECMO. If you see in India right now, only in the bigger hospital, tertiary care hospital like in CARE, where we can afford to do an ECMO. The smaller centers, they still can't afford to do an ECMO because they don't have that kind of support staff. So that is mean that it is the last resort most of the time? Yes, maybe you can say like that, but nowadays things are changing. We should not wait till the end when the patient will have multiple organ dysfunction. Not, let's say for lung you want to start ECMO and you delay to a level that now the kidneys are failed. The BP is dropping, requiring multiple support for the blood pressure. The heart is going down. That is not the time. You should think little early. So those indications where we should start ECMO, let it be a patient were having a lung failure or cardiac dysfunction, things are changing. It is like we are now doing little early, but yes, it is one of the let's say treatment or therapy or a support we usually think once conventional treatment fails.
But are there also any misconceptions, sir?
Too many misconceptions, that too in India. See, during COVID, where like the whole world came to know, or more so in India, regarding ECMO. Before that, hardly anyone knew about ECMO. We started doing ECMO long back since last 15 years. But still, COVID, see, even if it was such a pandemic the whole world was afraid of, there are few things which COVID taught us and maybe a common person came to know. Let's see, one of that is ECMO. But unfortunately, people got the misconception more than the correct concepts regarding ECMO. During COVID also, a lot of people, I don't want to name them, the big names, whoever was kept on ECMO, they all died.
Oh.
So they have big names. The singers are there, the politicians are there, who are kept on ECMO and during COVID or before that and after that. So there is a misconception throughout India, maybe throughout world, I am not very sure. People think that if somebody put on ECMO means they are going to die.
Oh.
This is not at all true. In my experience, over the last few years, we started doing ECMO more frequently. Yes, it takes some time to understand, to build a team. If you have a proper team and you are doing the best possible job, the chances of survival of a person who is on ECMO may go up to 60 to 70%. I can proudly say the ECMOs, whatever we have done over the last few years, the survival was up to 60%, which is equivalent to any of the Western countries.
Yeah.
So out of maybe 10 people, if you start ECMO, 6 to 7 people are going to get better and go home.
Sir, in critical care, they say everything is about decision making, right? So in that point, technologies like say bedside ultrasound or invasive monitoring or AI, changing ICU decision making, how is that helping you?
See, you have such wonderful questions, one after one you are bombarding me. So regarding, you see, bedside ultrasound, see, in the last few years, that is almost replaced stethoscope. You must have seen like somebody is thinking about a doctor means you always think that there is a stethoscope hanging on the neck. Nowadays, if you see, the ultrasound can do much more than a stethoscope. So we can see the heart, how is it functioning, if the heart there is an issue or not. We can see the lungs. We can see the abdomen if there is any fluid or anything else is going on. We can know a lot of things by doing an ultrasound bedside, which can be done within 1 or 2 minutes. And we can know like what kind of problem going on, what will be the effective treatment in those kind of situations. Decision making becomes very, very easy if you have a bedside ultrasound, which is now a norm in most of the ICUs. Apart from that, as you told, like the monitoring is very, very important in ICU. Every minute, every second, we should know what is going on with our patient. To have a proper monitoring, sometimes we keep things called arterial line, where we keep a small cannula, what we keep it for giving drugs and all into the artery, not into the vein. Through that, we can measure the blood pressure with each beat of the heart. See, this beat you have a BP of 121, the next beat it might be 125.
Correct.
So each beat we can see the heart rate, the blood pressure and all. We keep bigger cannulas in the veins through which we can give drugs. We can see that volume status of the patient. Do monitoring, which is the most important part in ICU. These are the things by which we can monitor more effectively, more efficiently with each and every minute passing. That is important and maybe the most important thing in ICU.
Yeah. But sir, when it comes to high quality critical care, okay, what are the biggest challenges, especially in India?
Yes. See, India, if you compare to the Western country, I've asked before one question. In India, uniformity is lacking. Okay. Uniformity in the sense like we have like metro cities where everything is available. You can go to second tier cities where maybe partially things are available. You'll go to rural India, things are not at all available. Resources are scarce there. And India, the population is second bigger issue. So it is always the resource which is going to be limited. You cannot give the same kind of care and maybe the resource availability is such a big issue. In the rural India, person may not get the simplest kind of medicine also compared to a metro city. So that is one of the biggest problem, what I believe, the resource and the population. Apart from that, see, India itself lies in a part of the world that is called tropical country, which is again you see mosquitoes, different forms of vector. Because of you see the dengue, this malaria, the scrub typhus, leptospira. These are mostly some vector-based disease, which are very, very unfamiliar if you go to Western country because of that climate.
Yes.
Our climate itself causes a lot of other issues to us. Unfortunately, we can't help it. And see, now this is the season where we get a lot of dengue patients during the post-rainy season, and maybe other form of tropical diseases. So these are the basic things. First thing I believe is the uniformity of the availability of the resources in India, which is a bigger problem. Second thing, maybe population itself is causing issue. And third thing is affordability. Because if you see the Western country, I'm not saying like which country and all, if you see the most of the European countries, health is free for everyone, at least the basic health. In India, it's not like that. Maybe government is trying their best to come out with one after one plan with which a common man who cannot afford otherwise, they are giving good amount of support up to some level. But beyond that, it becomes very difficult. So affordability is again a bigger issue in India. They are the three basic things apart from the geographical location of India, which comes in the tropic with tropical diseases which are more common in India.
Sir, there are life and death situations that happening in the ICU and you see them daily. How do you cope with it personally?
I think this is one of the most difficult question to answer. See, as a human being, even after practicing for 17, 18 years in critical care, it is not always easy to face a family and the patient is not going to survive, or the patient is so sick that chances of his survival is very less. And those kind of things are very, very difficult. So day in and out we see such kind of patients, we are discussing with the family and we are dealing with those kind of patients. It is no doubt very taxing. So you cannot have your mental peace seeing those kind of patients day in and out. Yes, it is difficult. We are trying our best to come out of that with some good family time whenever we get. Doctors, we are very poor when it comes to spend quality family time. Some exercise, I do some pujas. So regularly I do pujas so that my mind will be little cool. Otherwise it is very difficult to cope up this kind of situation in life.
Okay, sir, let's step it up. I have a bunch of rapid care questions, sir. I want you to answer in a word. Okay, let's do this. One word to describe ECMO.
ECMO is a real lifesaver when it is used appropriately in appropriate patient in appropriate time.
Okay. The biggest myth about ECMO?
The myth is most of the people who ever put on ECMO, they die. Actually, most of the patients who put on ECMO, they survive.
Right. Most underrated role in the ICU team?
The ICU team, they work day in and out till the patient is in ICU. Once the patient get better, they go out of ICU. Most of the people, they don't remember what all efforts has been put by the ICU team during the stay in ICU. This is one of the things we always miss. Yeah. See, at least by the time the patient get discharged, they should have some idea what all efforts and all we put on a patient when they are in ICU.
The toughest decision that you made in the ICU?
So every day we take some decision which is toughest, but the most difficult decision sometime when it happens is to pull the plug. Yeah. When we believe like the patient is not going to survive, it is kind of futile whatever you are doing. It is only to make him more and more suffer by doing more. And that kind of decision is not at all easy. You have to talk with your team. You have to have a common consensus with all the doctors who are treating. then you need to talk to the family, make sure they are in the same page and they are also thinking in the same line with empathy, with sympathy and everything. And that is one of the toughest decisions when we think this patient is not going to survive and we have to maybe pull the plug.
Chai or coffee during the long ICU shifts?
I like coffee, I'm a coffee man.
One gadget in the ICU you can't live without?
I think ultrasound.
If not a doctor, what career would have chosen? You would have chosen.
See, we are the kids where actually from childhood, everybody told you are supposed to be a doctor because you are a good student. I never thought anything what I could have been other than doctor, but I would have been done better if I would have been an engineer.
Oh, nice. And one final question, sir. Complete the sentence. Critical care means?
Team effort, empathy, compassionate, and the patient towards work will decide what critical care is.
So
it is always a teamwork.
Like you said, you are compassionate, you are empathetic, and you are passionate. Thank you so much, Misra Saab. Thank you so much.
Thank you very much to be here.
Right, sir.